relates to integumentary disorders and communicable diseases as it reflects and pertains to the pediatric population. Please stop the presentation and take a moment to review the learning objectives. Growth and development of the integumentary and immune system. Now we'll need to go back a little bit to anatomy and try to review and recall elements related to the skin. So the skin, it's part of what is called the integumentary system and is considered the largest organ of the body. In addition to accessory structures makes up for the integumentary system, and the accessory structures will be the hair and the nails. If you remember from anatomy, there are several major functions for the skin, probably the most important one being the function of protecting the entire body, the organs and other structures of the body against any type of injury that can come from the outside environment, regardless if it's an infectious danger as a bacteria or a virus, it can be chemical or any other type of injury. In addition to that, another major function of the skin is the body temperature regulation. At the level of the skin, by vasoconstriction and vasodilation, the body is able to maintain the homeostasis of the body in terms of maintaining a constant temperature. In addition to the vasoconstriction and vasodilation in the body temperature regulation, we have involved skin glands as there are the sweat glands that will help through the form of perspiration continuously and sweat in certain conditions. The other type of glands encountered in skin will be the sebaceous glands that will secrete oils that help in lubricating the skin and the hair. So bottom line, those oils are beneficial and will prevent an increased dryness of the skin. Another function of the skin is to be part of the immune system. There are some cells that will be present in the skin, that can be found in the skin, and they are part of the immune system. And we'll discuss about that in a second. Last but not least, in the functions of the skin, we'll need to mention the fact that the skin is a sensory organ, having different types of receptors, including nerve endings that will respond to pressure and pain and heat and cold. All those together make up for a sensory organ. I was telling you about the differences in the development of the child. The child cannot be seen as a small adult. They are completely different in terms of physiology, as well as in sometimes of structures of the body. So when we are looking at the integumentary system, it is present at birth. It's there. However, not all the functions of the skin are finalized. The skin of the infant, it's not able to perform part of the immune system. The regulation of temperature is difficult because they don't have enough fat, they don't know how to shiver, and their mechanism of vasoconstriction and vasodilation are still not mature enough. Along with the fact that they do not have mature sweat glands that cannot allow for losing heat when necessary. So we understand now that the skin, together with the mucous membranes, will prevent pathogens from entering the body. However, it's the role of the immune system to destroy the pathogen. And at the level of the skin, the immune system, it makes its presence by sending out macrophages, and those will be present inside the skin, will surround, ingest, and finally neutralize the pathogen. In addition to that, when talking about the immune system, this is totally immature in an infant. the infant is protected at the beginning when immediately after birth by the mother's antibodies that already cross the placenta, and they can offer this type of temporary immunity against certain disease depending on what the mother is immune to. However, they will not going to live long. They persist only for the first couple of weeks of the baby's life, and that's why the schedule for the immunization and the vaccination needs to start very early. We will start discussing the integumentary disorders by defining those that are the most benign and most common sometimes, and also easiest to treat. We'll start with the seborrheic dermatitis, or the cradle cap, how it's known, well, its more popular name. It's the condition that you can see on the top of your screen on the right side. Is this type of yellowish and scaly crusty patches that will be seen over the scalp. You will observe them more on that top area over the anterior fontanella. This is because the caregivers will be concerned and will be scared to vigorously scrub those crusts from the baby's scalp in order to remove them. Those crusts, those patches, are the result of an overproduction, an excessive sebaceous gland activity. It's totally benign, and the only thing that we need to do is to educate the caregivers and explain to them that those needs to be removed with every bath that they are giving to the baby. We can teach them how to use a fine-tooth baby comb after shampooing that will prevent the accumulation and the crusts and the patches that form on the scalp. Also, we need to educate them if there is a crust like the one that you see in the picture, to not try and remove it at once, because usually this type of crust, being very, very dry, will be tight, will be very tight, adhering to the delicate skin of the scalp, and the scalp can be injured in the process. What they can do in order to loosen the crust, they can use daily mineral oil, applying to it, and in a couple of days will go away. The second condition is the second picture that you see on your right side. It's called miliaria rubra, and this is a rash that has this kind of appearance of a pinhead-sized red papules that causes a lot of itches, it puts the baby at a high discomfort because of the itching. It's the result of exposure to extreme heat, or especially during the summer days, and can be the result of the fact that the baby may be overdressed. It also can be seen in febrile illnesses, and a lot of times it's confused sometimes with the rashes from one of the communicable diseases. What we need to do when we know that this is not related to a febrile illness is to educate the caregivers. And prevention is the main treatment, actually, by explaining that they do not need to overdress the baby. And there will be situations that, especially when the environment is extremely hot or the baby has fever, that the baby doesn't need the clothes, and the diaper is all that they need. In order to so the prevention is the main thing that we can do. Something else that we can teach the caregiver is to give the baby a tepid bath without soap, and those will allow to control the itching. And also, they can add small amounts of baking soda to the bath water to relieve the discomfort. Another condition that is very common, and we see a lot in a lot of babies, will be the diaper rash. It's very common in infancy, and is causing a lot of discomfort. Definitely there will be some babies that will be more susceptible than others, and that because they have a special type of skin, the skin that has an inherited sensitivity. In terms of clinical manifestation, so I will explain to you what happens whenever the baby is exposed to urine. The baby's skin is exposed to urine. You know that on our skin we have bacteria. Bacteria will start and decompose the urine and will produce an increased amount of ammonia, and this is very irritating to the child's skin. Some other cause for a diaper rash is a stool that is loose. Diarrhea usually has very low pH, is acidic, and will produce this kind of burning, chemical burn, and erythema in the anal region. So whenever the baby is prolongedly exposed to wet or soiled diapers, also in those cases that the parents are using the plastic or rubber pants, when they are not changing the disposable diapers often, or when they are not cleaning the diaper area, especially after bowel movements, we will see this type of condition. Sometimes, in some cases, the diaper rash may be the result of a sensitivity to some soaps or to some disposable diapers perfume. So we need to teach the caregivers not to use any type of fragrance type of diapers. In some cases, um, there can be an associated yeast infection, especially with Candida. Again, in this case, for the diaper rash, the most important treatment will be, again, prevention and teaching the parents on how to change frequently the diapers and not wait until the diaper is leaking, regularly checking for that. There is a tendency to allow the babies nowadays to stay longer and longer in the diapers because we have those type of disposable diapers that are kind of easy and convenient for the parents to use. That's why you will see sometimes babies in diapers up to age 3. Whenever they are using the non-disposable one, the washable diapers, we'll need to teach them how to use what type of laundry soap to use and how to pre-soak them, wash them in hot water with a mild soap, and if possible, to rinse them with an antiseptic added to the final rinse. So there is a whole process if they want to use the non-disposable, the cloth diapers. Also, it is better for them to dry the diapers in the sun or in a dryer because that will expose bacteria to either heat, dry heat, or to the sun, and that destroys bacteria and yeast. In terms of cleaning the diaper area, we'll need to teach them on how to wash the baby perineal area by using warm water and doing that front to back to prevent carrying the bacteria to the urethra, especially in girls. Also, they need to dry thoroughly after each diaper change, and that will improve to prevent the conditions. An extreme situation is what is called the candidiasis, and candidiasis is a result of infection with Candida albicans, which is responsible for the thrush and some cases of diaper rash. In those cases, what we'll see in terms of clinical manifestation, we'll see in the child's mouth a white coating that looks like milk curds. Usually the babies will be contaminated, will be exposed to Candida during the vaginal delivery if the mother has a vaginal infection. Also, it can be the result of poor hand washing practices or inadequate washing of the bottles and nipples. In addition, we may see it as a transient episodes of thrush and diaper rash after antibiotic therapy for some other kind of bacterial infection that the baby may have. And this is the result of an upset balance in the normal intestinal flora that will allow the Candida to overgrow. What we can do to treat that, we can use nystatin ointment or cream to the affected area. We can also use mycostatin or nilstat to the oral lesions every 6 hours. And good hygiene practices will always need to be reinforced. The fourth condition that we'll discuss in here will be the staphylococcal infection, which is a skin infection with Staph aureus. This is the most common pathogen encounter. And the infections can range from mild to severe and can happen in various parts of the body. However, the skin is the most often part that will be affected. Normally, the staph family of bacteria may be found in the nose or on the skin, and whenever the skin or the mucosa is injured, the bacteria may found its way in and cause an infection. On the skin, the lesions will look like pimples, may be red, painful, and swollen, and may have pus or drainage. Keep in mind that staph infections are highly contagious, and the transmission happens through direct contact with an infected area. Any contact with the personal items, such as hairbrushes or towels, may spread the infection. In order to prevent that, again, we are going back to good hand washing and keeping the injured area as much as possible clean to decrease the spread. Antibiotics can be used to treat the skin infection. Inside this category, there is a strain of bacteria that is called methicillin-resistant Staph aureus, or you can find it as MRSA. And this type of bacteria is highly resistant to the normal used antibiotics that normally we are giving for Staph aureus treatments. And because of that, an infection with MRSA, regardless if it's a skin infection or located in other parts of the body, may be very hard to treat. Whenever a child will get MRSA as an iatrogenic infection while in the hospital, we'll call it nosocomial or hospital or healthcare associated infection. However, in the recent years, we can see more and more cases of MRSA that are acquired as community-associated infection. Question number 6. What integumentary disease is commonly known as cradle cap? Diaper rash, seborrheic dermatitis, miliaria rubra, or the flail chest? Seborrheic dermatitis is commonly known as the cradle cap. Another type of infection of skin infection in children is impetigo, and impetigo is a superficial bacterial skin infection. It has two forms. It can be seen in newborns, and usually those lesions are a bullous type of lesion. They have fluid filled lesions on the skin, and it's caused by Staph aureus. In the older children, the pathogen involved will be from the strep family, the group A beta hemolytic strep, and usually there will be no blister-like lesion. It will be a non-bullous type of condition. Keep in mind that it's highly contagious and can spread extremely quickly. Once a child in the nursery has impetigo, many of them, and sometimes all of them, can get it very, very quick. In terms of treatment, the child can be treated with oral antibiotics. It can be penicillin, or for those that have a sensitivity to penicillin, we can use erythromycin for 10 days. For the crust, for the skin lesions, we can use Bactroban ointment. Make sure that the treatment will not going to be stopped and will be completed, because there is a high risk in older children to develop rheumatic fever or acute glomerulonephritis if the treatment is not done quick and the way that it should be. In terms of care, we need to make sure that the caregivers understand how highly contagious this condition can be, and the hand hygiene is essential. Also, if the child is hospitalized, the personnel taking care of this child must follow the contact skin and wound precautions, and they need to come in the room having gowns and gloves at any given moment, especially until the skin lesions will be healed. Along the time that the child has the crust on it, they will need to follow this type of precautions. Definitely the child needs to be segregated from other children to avoid spreading the disease, both in terms of not being in the community and also from siblings. In order to take care of the crust, what we can do is also soaking them off with warm water, and immediately after to apply the topical antibiotics. Um, the older child can receive all the treatment at home. However, the same type of precautions need to be followed by the family. Um, it is a good idea to remind the caregivers that the crust and the drainage are contagious, and because the lesions are very itchy, the child needs to be stopped by touching them as much as possible, have their fingernails cut short, so he or she will not going to scratch and actually pass it over to another part of their body by kind of over-infecting himself or herself. We'll discuss now the acne vulgaris. Acne can have a variety of forms, from a mild case of the patient having just some oily skin with a few blackheads to the very severe type with cystic lesions that by healing will leave deep scars. It's especially it can be very traumatic, especially in adolescents, and that's because at this in this group, this age group, the patients will want to be attractive, will want to be popular, and whenever they have those zits that can be severe in some cases, they may go through a lot of anxiety or shyness and even social withdrawal. When we examine the patients in terms of clinical manifestation of the acne, what we'll see is what is called a comedon. They can be blackheads or whiteheads, and the difference between them is the fact that in a blackhead, that comedon is exposed to the air, and the bacteria, by processing the fat in the comedon, will get that black color, while the whiteheads, it is just covered comedon. They may show up with papules or pustules that can show on the face, on the back, the chest. It can be on the upper shoulders and the arms. The cause for that, the factors that contribute to the appearance of acne are an increased hormone levels, and especially androgens. Maybe some hereditary factors, maybe irritating substances, as the fact that they are vigorously scrubbing of the face. They may use cosmetics that have an oily base. And on top of all this is an overgrowth of anaerobic bacteria. In the process of forming a comedon, we need to understand the process. We need to go back to the structure of the skin. And you remember that each hair follicle will have an associated sebaceous gland that will increase its production of sebum or oily secretions in adolescence. So whenever the sebum will be blocked by some epithelial cells, will become trapped in the follicle. If also some anaerobic organisms will be trapped inside, a collection and inflammation will start that will develop into papules and pustules and nodules. What can we do in terms of treatment? We treat this with topical medication as benzoyl peroxide or tretinoid, which is retin A. It's a retinoid, it's a vitamin A based product. They come in a variety of forms. They can be topical cleanser or lotions or creams or bars and gels. For mild types of the condition, we'll use those topical applications that can be done once or twice daily based on severity of the case. Now, we need to advise our patients that we do not apply those type of products on normal skin. We also do not allow those products to get into the eyes or nose or other mucous membranes because they are toxic. We can add antibiotics as erythromycin or tetracycline for what is called an inflammatory type of acne. The treatment can be long-term, at least sometimes 6 to 12 months. For the severe cases of the acne, of the inflammatory acne, we can add Accutane or isotretinoin. Um, there are some controversies over the use of this medication, especially because it has um, a lot of side effects, some of them being very serious, including depression, suicide, and there is also known that Accutane can produce fatal malformation in a fetus if a woman will become pregnant while taking the medication. We also need to add to the education how and reinforce, especially for the adolescent, a teaching on how to wash those lesions. And those lesions need to be washed gently with soap and water and not being scrubbed vigorously because that will injure the skin, even the skin that is still intact. When we try to remove the comedones, those need to be removed gently. And by using, whenever we do that, we need to use careful aseptic techniques. If we do that carefully, we'll have no scarring. The skin will not be injured and a scar will not gonna follow. Um, there is some common or kind of urban legends that chocolate and fatty foods may cause acne. That's actually not true. We can reassure the family and the patient, the adolescent, that eating chocolate and fatty foods will not going to cause the acne. Um, However, if we have a well-balanced, nutritious diet, that will promote a healthy type of healing. Question number 7. Tell whether the following statement is true or false. When Accutane is prescribed to a female client, a pregnancy test must be given before beginning the treatment. The answer is yes, it's true. Isotretinoin is a pregnancy category X drug. It must not be used at all during pregnancy because of serious risk of fetal abnormalities. To rule out pregnancy, a urine test is done before treatment is begun. And for the sexually active adolescent girls, an effective form of contraception must be used for a month before beginning and also continue during the Accutane therapy. Fungal infections. Some types of fungi that usually would live on the outer layers of our skin or hair or nails may develop and may exacerbate themselves and they can start a superficial infection. The ringworm, popularly named, or the tinea, is the term applied to those infections. We have more than one type and we'll discuss a few of the elements for each of them. First of them, we'll discuss what is called the tinea capitis, or the ringworm of the scalp. It is caused, again, by a microorganism that is called Microsporum odorhei. And it's transmitted from person to person through combs or towels, hats, barber scissors, and sometimes from direct contact. It's not so common. Whenever it's transmitted from an animal to a child, it's called Microsporum canis. In terms of clinical manifestation, you have a picture on your right side of the screen. It starts as a small papule on the scalp and it spreads, leaving scaly patches of baldness. The hair in those areas will become brittle and will break off easily. The treatment is an oral antifungal that is called griseofulvin. The treatment may be prolonged up to 3 months and sometimes even more. Therefore, there is a need to reinforce and educate the caregiver and the patient on compliance with that. And so the moment that the child will be properly treated, they may go back to school. And also, you can assure both the caregiver and the child that the hair loss is not permanent. And once the treatment is fulfilled, the hair will grow back. Another type of tinea is tinea corporis. It's a ringworm that will affect the epidermal skin layer of the body. It can be contracted from the contact with an infected dog or cat. The lesions will be scaly rings with a clearing in the center and can happen everywhere on the body. They may resemble the lesions of the scalp, and the treatment is also topical antifungal agents is clotrimazole or miconazole. Griseofulvin that we were using in tinea capitis can also be used for that. And you can see a picture on the top of your screen. You see that some of them can have this kind of geographic type of lesions, very extensive. It looks like almost a tattoo of the skin, but that's the fungal infection. And you have on the left side a lesion on the face. Tinea pedis, or the ringworm of the feet, it's popular, it's known in a lay term of the athlete's foot. There will be a scaling and cracking of the skin, especially between the toes, and it's transmitted by direct or indirect contact with skin lesions from infected people. It can be transmitted by contaminated sidewalks or floors. Usually it will be a pool deck or a shower stall that the patient was touching it with a bare foot. It's common in adolescents and in young adults. It's very prevalent among school-age children because at a certain point, it was very popular to use plastic shoes. In terms of treatment, we can use, again, an antifungal as a griseofulvin by mouth. We need to have educate regarding washing the feet with soap and water and gently removing the scabs and crust before applying a topical agent as tolnaftate. During the chronic phase, we need to continue to use the ointment and to keep a very scrupulous food hygiene. We need to teach the patients in terms of frequently changing cotton socks and avoiding any type of plastic footwear or clothing. The topical agent may be needed for up to 6 weeks sometimes. The last type of tinea is called tinea cruris, or known as the jog itch, and it's a ringworm that shows up in the inner thigh and inguinal area. It's a similar organism with the one that is causing tinea corporis, the one that we see on the body. It's very common in athletes, somehow uncommon in pre-adolescent children. In the manifestation of it will be an itchy pruritic lesion of the inguinal area. The treatment is just the same as for the other types of tinea, and in some cases, the sitz bath might also be soothing. We'll talk now about the parasitic infections, and we'll start by defining what a parasite is. Parasites are those organisms that can live either on or within another living organism, and they use that organism for their nutritional needs in order to obtain their food supply. We'll discuss here about lice and scabious mite that are very commonly encountered in pediatric population. I will also mention that when we talk about infections, we call a parasitic infection an infestation. So we are talking first about pediculosis, and pediculosis can be of the scalp when it's a head lice, which can be of the body when it involves body lice, or a pubic lice in the genital area. By far, the head lice are the most common infestation in children, and keep in mind that animal lice are not transferred to humans, regardless if they are pets, or other wild animals. And that's because the animal lice are looking for a higher body temperature for surviving, and we don't have that. Humans have lower body temperature than other living animals. So the head lice usually are passed from child to child by both direct and indirect contact through combs or headgear or bed linens. In terms of manifestation, the lice, if you are trying to look for them by spreading away the hair and trying to find the lice itself, that they're tiny black organisms, you will not going to see them because they are running away from light. They're hiding from light. However, they will lay their eggs, and the eggs are called nits, on the head, and they attach those nits with a highly adhesive glue to the hair strands, pretty close to the root of the hair. So the nits can be seen, and they are tiny pearly white flakes that attach to the hair shaft, and they pretty much resemble the dandruff. However, as opposed to dandruff, that by blowing over it or by shaking the hair strand, the dandruff will be easily flicked away. Those nits are tightly attached and cannot be removed. Normally, the cycle of the lice is the following: the nit will be attached to the hair in about a week. The nit will hatch, and the lice become sexually mature in about 2 weeks. So, in about 2 weeks, one egg can, you know, um, multiply and provide more and more. So the infestation is very, very quick. What we see is a severe itch of the scalp, and this is usually the most obvious symptoms in the head lice cases. What we can do to treat that, we have a wide range of non-prescription medication over the counter, as Pronto and Grid and A200, and they all contain an extract from a plant, chrysanthemum. It's a flower. Um, we have another one that is called Nix, that contain a different type of substance that is called permethrin. Those are considered safe and usually effective in most of the cases. They are killing the lice. However, we need a second treatment in 7 to 10 days to kill the nits after they have hatched. So it's not a complete solution at once. There are some over-the-counter preparation that do not effectively, if the we can. So if the over-the-counter medication is not able to effectively take care of the problem, we have prescription medication that can be used as malathion. However, they have some side effects, especially if there are any scratches on the scalp. Those will become some open sores. It's kind of a superficial burn of the scalp. Another product is called Lindane. That is very useful for many years and is considered safe. However, make sure that this will not going to be overused or misused, because then it can become toxic to brain and nervous system. So how do we do this? In order to use the product, we will wet the hair with warm water and we apply the medication like we apply any ordinary shampoo. About 1 ounce is needed. And the head will be lathered for several minutes to distribute the substance everywhere and cover the hair, the scalp and the hair completely. Usually you will have some directions on the label that you can follow. After applying it, you rinse thoroughly the head and you dry it. Once the hair is dry, now it's the second stage of it. We need to comb the hair with a very a fine tooth comb that usually we dip it in warm white vinegar in order to remove the rest of the nits and the nit shell. Those shampoos usually will dissolve the glue of the nits that keep the nits on the hair strands. We will need to repeat the treatment in about 2 weeks in order to make sure that we didn't miss any of the previous nets or any of them didn't hatch in the meantime. Now, we, of course, we need to avoid getting medication into the eyes or on any mucous membranes. And if you provide the treatment in a facility, make sure that you're using all the contact PPE necessary. Scabies is a skin infection that is caused by a mite that is called Sarcoptes scabiei. So the female mites, usually they will burrow themselves in areas between the fingers and toes and in inguinal area, in all those warm folds of the body like axilla and the groin to lay the eggs. The burrows will become visible. They will become as reddish dark lines, and the mite can be seen as a black dot at the end of the burrow. As a result of this tunnels that they are, they are producing under the skin, there is a severe itching, and as a result of that, the patient will scratch those areas, and sometimes a secondary infection can follow. Now, in terms of treatment, we are using permethrin cream and Lindane, with the exception of the face. Now, what's interesting about the scabies is that usually the face will be spared. There will not be lesions on the face, so it's not needed to be used on the face. We need to follow the directions on the medication. However, how do we do this? So the body will be first scrubbed with water and soap, and only after that we'll apply the lotion on all areas of the body except for the face again. And permethrin is the preferred treatment because it has a low risk for neurologic problems. We'll leave this lotion on the body for 8 to 14 hours. Usually we do it in the evening. We put it after the evening shower. We go to sleep. And in the morning, we'll be washed off with, again, with warm water. We'll avoid the close contact with a child for the up to 30 to 60 days, and everyone that was in close contact with that child will need to have the same treatment. The symptoms may persist for weeks after that, even if the mites have been successfully eliminated. So this is something that we need to educate the families that linens needs to be changed daily and washed thoroughly, and everyone needs to be treated in the household. However, the rash and the itch may persist for several weeks. Discuss now about allergic disorders, and there are many people, millions of Americans, and more than that, even worldwide, that have allergic diseases, and a lot of them will start in the childhood. Whenever a child has an allergy, they may also exhibit poor appetite and sleep and restricted physical activities, and that may result in both a modified physical and emotional development. We know by now that children that have parents or grandparents with allergies will be more prone to develop allergy on their own. An allergy, regardless what type of allergy is caused by a sensitivity, a hyperreaction to a substance that we call an allergen. And the allergen is that antigen that will cause an immune response from the body. And there are thousands of allergens out there. Anything out there in the environment may be an allergen at a certain point for an individual. The most common ones, and probably having the highest rates of producing allergies, will be pollen and mold and dust, animal dander and insect bites, tobacco smoke, nuts, chocolate, milk, fish, and shellfish. We also have drugs that can create allergies, and the most common ones will be aspirin and penicillin. Some plants or chemicals can also cause allergic reactions on the skin. Now, the way that those allergies are able to reach our body may vary. It can be through the nose, throat, eyes, skin, digestive tract, and bronchial tissues at the level of the lungs. And you can see that everything that actually comes in contact somehow with the outside environment can be a route for an allergen to come in. Whenever we encounter for the first time an allergen, there will be no reaction. However, there will be an immune response that will start, that will be stimulated. The B lymphocytes will be stimulated, and they will make what is called an immunoglobulin E antibody. This type E attaches to those big cells that we have in the skin. They are called mast cells and the macrophage. When the body comes in contact again with the same allergen, this allergen will be recognized, and the response, a full response that will include releasing of histamine, will be produced. In order to make a diagnosis of an allergy, we need to take a very careful history and to perform a physical examination. And in some cases, we'll do skin and blood tests. And when we're talking about the blood test, we'll do a complete blood count, a serum protein electrophoresis, and even an immunoelectrophoresis to try and identify what type of antibodies are involved. The skin testing we are performing it in order to identify those allergens that can be removed from the environment. When we suspect a food allergy, we do what is called an elimination diet. We eliminate those food elements that we know that cause, in general, allergies like eggs and milk and chocolate and nuts. When the specific allergen was identified, we can start educating our patients and caregivers on how to avoid them. In some cases, that's impossible to completely avoid that allergen. And what we do, we can offer an immunization therapy by injection. And that is called the hyposensitization or immunotherapy. So we'll schedule a set up meeting, we'll set up meetings, a schedule for injections that will gradually increase the doses until we have what is called a maintenance dose. We are providing small amounts of the allergen in order to make the body get accustomed to the presence of it. For all of those injections, when we provide them, the child should be in the office for 20 to 30 minutes after the injection in order to see that a reaction will not occur. If it happens, because it's an allergy and sometimes can be severe, the treatment will be epinephrine. Those severe reactions can be uncommon. However, we need to be on the safe side and observe them for that amount of time. The symptomatic relief for allergic reaction is through providing antihistamines or steroid therapy. However, we still can understand why the best treatment is prevention, not exposing the patient to that allergen. The first time a child comes in contact with an allergen, no reaction may be evident. The next time the child comes in contact with an allergen, what does the body release? And the answers are histamine, immunoglobulin E, B lymphocytes, or immunoglobulin E antibody. The answer is histamine. The first time the child will come in contact with an allergen, no reaction will be evident. However, an immune response is stimulated, and the lymphocytes B will make immunoglobulin E antibodies that will attach to the mast cells and macrophage. And while coming in contact again with the same allergen, the response will occur by releasing the histamine. And the histamine is the substance that is causing the symptoms associated with the condition called allergy. There are some special types of allergy, and inside this category, we'll discuss here the atopic dermatitis or infantile eczema. It's considered, at least in part, an allergic reaction to an irritant. It's very common in the first year of life and usually will show up after 3 months. Is less common in breastfed babies and especially before they are given additional foods. So in order to put the diagnosis of atopic dermatitis, we'll have to look into a few factors. There is a hereditary predisposition. There is someone in the family that was showing that also. There was exhibiting this type of response also. There is a hypersensitivity of the deeper layer of the skin to protein or protein-like allergens. One important point that I would like to make here is that most of our allergies are to some proteins. Most of the times our body will recognize proteins as non-self, and most of the allergies will be to protein or protein-like substances. And the third factor will be that the allergens to which the child is sensitive can be inhaled, ingested, or absorbed through the direct contact. And as examples to that, I can give you different types of foods, wool, house dust, mites. In addition to that, those children that have this type of eczema may have other type of allergy conditions as allergic rhinitis or asthma later in life. In terms of clinical manifestation, what we'll see, as you can see in this picture, the eczema will start on the cheeks and will spread to the extensor surfaces of the arms and legs. And eventually, at a certain point, will cover the entire trunk. This initial reddening of the skin will be followed by the formation of papule and vesicle formation that are very itchy, and the child will scratch as a result of scratching, the skin will weep, and as a result of that, by healing, there will show up crusts. Whenever the skin is injured or the mucosa, those areas can be secondary infected by strep or staph bacteria. In terms of diagnosis, there is a full list of common allergens that can be involved as food allergens, and in here we have the egg whites and cow milk and wheat products and orange juice or tomato juice. We can have inhalants as house dust, pollens, and animal dander, or different types of materials in the household as wool or nylon or plastic. Definitely, if you just by me saying all those elements, you can understand that the diagnosis is is not simple. And what we do is called a trial by elimination. We can do skin testing. However, it's not considered valid in a very young children, in a very young child, and because of that, it's discouraged as a diagnostic method. We can do an elimination diet to rule out offending foods. In terms of substituting those offending foods, we can use hypoallergenic diets by using soy formula, vitamin supplements. Whenever the skin condition shows improvement, we can add gradually, one at a time, at an interval of about 1 week, the foods that were eliminated. If no effect is noted, this food will continue to stay in the child diet. If any type of allergy is seen again, that food element will be completely eliminated from the child's diet. How we can treat that? We can use oral antihistamines and sedatives that will relieve the itching and allow for the rest. We can use oral antibiotics if we have a superimposed infection, such as those with staph or strep. We can use, if there is no signs of infection locally, we can use topical cortisone ointments to relieve the inflammation. Colloidal bath or wet soaks can be used to soothe the itching. The water should be tepid, and no soap should be used because the soap has an increased effect of drying skin. In terms of inhalant and contact allergen, those should be avoided as much as possible. In the child's bedroom, window drapes or curtains and dresser scarves and rugs should be removed. All those elements that can carry dust and mites and dander. Everything should be washed frequently. The furniture should be dusted and washed again frequently. The crib mattress should have a non-allergenic cover, and that should be washed frequently. And feather pillows must be eliminated. Stuffed toys should be washable. You can see that everything that can remove as much as possible from the dust and particles that can become allergens in the child environment. Also, we need to make sure that the house do not have any kind of damp basement or anything that can harbor molds, because those can shed allergenic spores also. The same thing to look inside the bathrooms to remove any kind of mats or carpets in the bathroom that can be wet and harbor molds or mildew. Especially, and this is especially essential in those kind of warm and humid climates. In addition to the atopic dermatitis, we can have other types of skin allergies that will include the hives or urticaria, the giant swelling or angioedema, and rashes that can be caused by outside allergens as poison ivy, poison oak. The skin rashes are very common in children. And in some cases, some infection diseases can cause an allergic type of reaction too. Um, in terms of clinical manifestations, we have the hives that can appear in different sizes on different parts of the body and are usually caused by food or drugs. They can be bright red and itchy and can occur on the eyelids, tongue, mouth, hand, feet, everywhere. When affecting the mouth and tongue, hives can cause difficulty in breathing. Hives in the stomach that appear on the mucosa of the stomach can cause pain and nausea and vomiting due to the swelling. Foods as chocolate, nuts, shellfish, um, berries in some cases, other raw fruit and fish. Um, those are all possible food allergies. In addition to that, we can have drug allergens as aspirin, um, laxatives, anti-inflammatories, antibodies like penicillin. And sometimes it is very hard to identify the cause for them. In terms of treatment, the main treatment is aimed to reduce the swelling and relieve the itching. If the allergen can be identified, it will be removed from the child's environment. Um, if the allergy is to a certain food, that food must be eliminated from the child's diet. We can use antihistamines, topical or systemic, to relieve the itching and reduce the swelling. For plant allergies, there is poison ivy, poison oak, and poison sumac as most common causes of contact dermatitis. Those allergies are particularly common during the summer. And the cause for the allergy is the potent oil that is present in all parts of those plants that by scratching the skin and injuring the superficial layer of the skin, this oil is um, uh, getting to the deeper layers of the skin and producing a reaction. So the reactions can vary from a slight inflammation and itching to severe extensive swelling, um, and they show up as pruritus and sometimes tiny blisters that can weep and can continue spreading the inflammation. In terms of treatments, we can use antihistamines or oral corticosteroids to relieve itching and prevent scratching. We can use cool soaks and calamine lotion or topical corticosteroids to minimize the discomfort. The main prevention is to recognize and avoid those poisonous plants, and we need to educate the caregivers and also the children, especially those that are spending a lot of time outside. If possible, those plants should be removed from the close environment of the houses. Bites. Um, Children are very active and inquisitive, and in some um, situations, they may be exposed to bites along with insect stings and bites. Um, in most cases, the bites can be minor, and that is especially if the skin is not broken. So we'll talk first about the animal bites, and it's obviously that children enjoy pets. However, they need to the caregiver needs to understand that this encounter can become dangerous, especially with pets that the child doesn't know they are not the family pet, and sometimes even family pets can become dangerous, and especially the wild animals. Most common are the dog bites, and now most of the dogs, especially those that are pets, are vaccinated for rabies. So just a few dogs have rabies. And as a fact, if you really want to look into that, more domestic cats can carry rabies than dogs. Um, Whenever a bite from an animal happens, that pet will be withheld until it can be determined if it was vaccinated against rabies or not. If not, the child must undergo a series of injections to prevent a disease that can potentially be fatal. And in this series of injection will provide both active and passive immunization. The active immunity is established with 4 injections of the vaccine, the rabies vaccine, beginning on the day of the bite and on days 3, 7, and 14. In addition, we are giving immunoglobulin to provide protection from the first day. How do we treat when we see a bite like that? We'll vigorously wash it with soap and water. We can use an antiseptic solution as 70% alcohol or povidone iodine, um, and that can be and that will be done after the wound was cleaned with soap and water. The wound will be observed for signs of infections um, until it is well healed. Make sure that you report any type of animal bite, um, both wild animal and household animals. All the bites need to be reported. I think that for California there is a law that will put a hold on the dog um, or the cat if they are biting a human. Um, Children should be educated very soon about the danger of animal bites. Um, in addition to the household animals, children can be injured by skunks, raccoons, bats, squirrels. All those animals can provide can bite and can carry rabies. Spider bites. Um, Spider bites can cause a serious illness if untreated, especially those that are black widow spiders, brown recluse spiders, or scorpions. Those will demand the medical attention. What we need to do immediately after the bite is to apply ice to the affected area and look for medical help immediately. The ice will limit the absorption of the poison that they are putting inside the tissue with their bite. Tick bites. Very common in the area where we live. The wood ticks are carried by chipmunks and ground squirrels and weasels and all those tiny rodents. Um, so the most cases will be found in South Atlantic, South Central, and Southeastern United States. Ticks can be carried inside our houses by our pets, especially the dogs. Cats can bring them too. Um, there is another type of a tick that is called the deer ticks. Um, they are carrying a microorganism that can cause Lyme disease. Um, and this is also very common in our area. Um, in Lyme disease, the first stage of the disease becomes with a lesion at the site of the bite. It looks like a macule with clear centers, and um, in several weeks to months later, if the patient is not treated, they are getting into what is called the second stage. And in second stage, they will have central nervous system and heart symptoms. With the third stage that can occur a month to years later with arthritis and neurologic disorder, bone and joint disease. So Lyme disease, every tick bite needs to be treated with antibiotics as soon as possible to prevent the development into stage 2 and 3. Also, we can prevent tick bites by educating about wearing long pants and long sleeve shirts when they're hiking and also wearing insect repellent. The pant legs should be tucked into socks to prevent from a tick to come from under. Whenever the tick is found on the body, alcohol must be applied and the tick carefully needs to be removed with the tweezers. So it's essential to prevent the release of a pathogenic organism like Lyme disease by crushing the tick. That can release the pathogen and through the bite can infect the patient. Snake bites. Also, just like the spider bites, will demand immediate medical intervention. The wound needs to be washed and ice applied, and the involved body part needs to be immobilized to prevent the spread of the toxin. Also, a prompt medical support needs to be offered. Other types of insect stings or bites, some can be fatal in those individuals that are already sensitized. Um, Swelling can be localized and sometimes can be extensive, including an entire extremity. In other cases, a full anaphylactic shock can develop with circulatory collapse, airway obstruction. And death can be as quick as 30 minutes if the child is untreated. The treatment is injection with epinephrine, antihistaminics, and steroids. For those children that are having a sensitivity to insect bites, they need to wear a medical alert bracelet and carry their own anaphylaxis kit that will contain the plastic syringe of epinephrine and an antihistaminic. School, nurse, teacher, anyone who cares for the child should be alerted that the child has an allergy, and they should be aware where the child's kit, anaphylaxis kit, is. Burns represent a very frightening type of injury, especially when it happens in a child. More than 70% of the burn accidents will happen in children younger than 5 years of age. And if you really look into that, we can agree that nearly all childhood burns can be prevented. Um, and as an effect of a burn happening to a child, there will be a lot of guilt for the family, for the caregivers. Um, the burns are the effect of a child being curious and exploring, and that, if comes in the association with a failure to be supervised, will may lead to a burn. So we have different types of burns in terms of their the cause that will produce them. We can have those produced by hot liquids, very common in small children, that will pull on a coffee maker cord or on a pan that has hot liquid from the stove, and they're called scalds. It can happen also in small children that are left alone in a bathtub or introduced in a bathtub that will was the water was not checked before. There are another cause for burns will be fire. And that's the second most common kind of burn in children because children are fascinated by fire. They like to roam around fireplaces or campfires or room heaters, or they like to play with matches, especially if they are being left alone in a building. They can, by playing with matches, everything can catch fire. Um, so there need to be a lot of care when we are using smoking materials um, around the house. Even a cigarette lighter should contain a child-safe mechanism to prevent from a child to be able to use it. The third cause will be electricity, and usually that can cause severe facial and mouth burns that will bite on an electrical cord that is plugged into a socket. Now, if we need to classify the burns by type. The type will be according to the depth of tissue involvement. They can be the type 1, called superficial or first degree burns. The epidermis is injured, but there is no destruction of the tissues or nerve endings. Um, you, what the clinical manifestation will be erythema, edema, and pain. However, the regeneration is prompt and quick. The healing time is pretty short, 2 to 5 days, with some peeling of the skin and no scarring may be seen. Sometimes there will be a slight discoloration. We have the second degree burn or the partial thickness when in addition to the epidermis, the underlying dermis is both injured and destroyed. The blisters will occur. However, the regeneration of the skin will occur from the remaining basal viable cells in the dermis. So in this type of burn, the healing time is a little bit longer. If the burn is superficial, it may take up to three weeks, and no grafting, no surgery is needed. If it's deep with no infection, it may take up to a month, and if infected or covert to full thickness, it may take even longer. We have the third type, or the third degree burn, when the epidermis, dermis, and nerve endings are all destroyed. What we see is a burn that goes down to the subcutaneous tissue and may include fascia, muscle, and bone. Usually large areas will require grafting, and the treatment may take months and sometimes years, and sometimes they will even require subsequent surgery in order to treat the scars that are retracting. In terms of treatment of burns, we'll start with the fact that it's an emergency treatment, and for superficial burns involving small areas, the cool water is an excellent immediate treatment, followed by application of cool compresses or cool water to inhibit what is called the capillary permeability and losing the water through the injured area. And that will suppress the edema, the blister formation, and will decrease the tissue destruction that happens underneath by the heated area. Ice waters or ice packs should not be used because they can create the cold, the freezing type of burn, will increase the tissue damage. What we can do, we can also immerse the burned extremity in cool water to relieve the pain and to prevent a further thermal injury. And this can be done after the airway and breathing and circulation have been observed, especially in those cases that are extracted from burning environments. However, if the burn is involving a large area of the body, this procedure should not be done because there is a danger of producing hypothermia in the patient. For the special case of a fire victim, we need to address especially the airways to observe for signs of smoke inhalation and any respiratory burn. Clothing should be removed immediately to inspect the whole body for burned areas. In addition, the clothing may retain heat that can add additional tissue damage. All burn victims should be transported to a medical facility for assessment. And it's preferable to be done in a facility that has special burn unit capabilities. Now, if we are looking to the superficial burns, those can be treated as an outpatient, clean in an outpatient basis. The area will be clean, an anesthetic ointment will be applied, the burn will be covered with sterile gauze or dressing. An oral analgesic may be needed to relieve pain. Please do not intentionally break the blisters because that will increase the risk of a superinfection and added infection in that area. However, if the blister is already broken, that can be debrided, cut away. The patient needs to be seen in 2 days to inspect for signs of infection. We'll instruct the child, depending on the child's age and the caregiver, to keep the area clean and dry, no bathing the area until the burn is healed, and that usually happens in about 10 days. For the partial and full thickness burns, in sometimes it's hard at the first, when we see the patient to distinguish between a partial and a full thickness. Especially in the presence of the infection, a partial thickness burn may be converted into a full thickness one. And for those having extensive burns, a great amount of the full thickness burn often exists before it was even, we were able to estimate the extent of it. So for the full thickness burns, those will require a lot of attention and skills, and usually the treatment in a skilled facility, in a facility that has a capability of having a burn unit. For the treatment of those with moderate to severe burns, we have a critical phase that is called the first phase, that is between the 48 to 72 hours after the burn happened. During this time, an extracellular fluid will pour into the burn area and will collect sometimes in very big quantities. And as a result of that, there is a full dehydration of the body. And obviously, on the outside, we'll observe edema with symptoms of severe shock because of the shift of the fluids from the intravascular space inside the interstitial space. In terms of clinical manifestation, intense pain may not be a major factor because the nerve endings were compromised. However, the symptoms of shocks will be present with low blood pressure and rapid pulse, pallor, and a considerable apprehension. We need to give a lot of attention to the airway. and we need to determine if there is an adequate airway present, and if there is no need for ventilation, for intubation and ventilation of the patient. If the intubation is not possible, a tracheostomy will be performed. Inhalation injuries are a leading cause of complication in burns, especially if there are burns associated around the face and neck. We need to, and that happened in a small enclosed space. We need to suspect an inhalation injury. Also, some toxic substances and the heat can cause additional damage to the respiratory tract, both the lungs and the trachea. In terms of treatment, the primary concern is to replace all that fluid that has been lost and shifted at the level of the burn areas. We are using what is called the rule of 9 to calculate the percentage of the total body surface burn. In children, we can use the Lund-Browder chart that it seems to be a little bit more accurate than the total body surface. So in the Lund-Browder chart, the child's age and the percentage of the area affected by either second degree, which is the partial thickness, or the third degree, which is the full thickness burns, are calculated when using TBSA. We will need to have an IV infusion site, and fluids must be started as soon as possible. Most often we are using ringer lactate or isotonic saline. We can also give plasma because a lot of the proteins will leak also. Because this patient will probably will face a long stay in the hospital, we need to start them on total parenteral nutrition. In terms of oral fluid, especially for those extreme cases, in the beginning, the oral fluids can be minimized for the first days or completely omitted. If needed, we can add an NG tube to prevent delayed gastric emptying due to acute gastric dilation, which is a common complication of burns. It can result in vomiting. IV fluids will replace the fluids needed. Once the bowel sounds are heard, returned, we can start with oral feeding, and the nasogastric feeding may be needed sometimes to supplement the intake. We need to observe and note the urine output and diuresis. Because of the signs of the shock and the decrease in the blood volume, this needs to be monitored closely. We consider a renal shutdown as a big threat, and we are aiming to see an output of 1 to 2 milliliters per kilogram and per hour for children that are weighing about 30 kilos or less, or 30 to 50 milliliters per hour for those weighing more than 30, and it's the same number for the adults. We will use an indwelling catheter in order to accurately manage the urine and also observe for specific gravity. We'll need to provide some type of infection control because, especially in the extensive burns, the integumentary system, which is the primary defense against infection, is lost. There will be prophylactic antibiotic therapy administered. In addition to that, a booster dose of tetanus toxoid will be required. In terms of wound care, and this is the specific type of treatment for the burns, we have what is called an open method and a closed method. The open method of burn care is most often used for superficial burns, for face and burns of the perineum. In this type of care, the wound is not covered. However, an antimicrobial ointment is applied topically. And to do this type of care, we need to keep a strict aseptic technique. In the closed burn method, we are using non-adherent gauze to cover the burn. Whenever we are moving the patient, we need to be very careful in moving them in order to not increase any type of injury or pain to the patient. Dressing changes usually are very painful, and infection is one of the most frequent complications. In both methods, we may perform what is called daily debridements or removal of the necrotic tissue. Sometimes this can be preceded by hydrotherapy, use of water in treatment that the use of water can remove the dead tissue. Also, debridements can be extremely painful. Depending on the size and the extent of them, some analgesics might be administered before the therapy, or the therapy, the exchanges, depending on the depth of the and the extent of the injury, will be done under general anesthesia. For extensive injuries from burns, we can use grafting, and this is providing skin to the area where the skin was destroyed. The grafts can be homograft, heterograft, or autograft. Homografts and heterografts are considered temporary grafts. A homograft consists of skin taken from another person. Usually this will be rejected and sloughed off after 3 to 6 weeks. For allograft or the homograft, we are using skin from cadavers. This skin can be stored and used for several weeks. A heterograft is obtained from animals, usually is pig. Also, there are some places that are using tilapia skin nowadays. Those are very temporary. The heterograft is only for a couple of days. An autograft will be the permanent type of treatment that we are looking for, and it consists of skin that is taken from the patient's own body from an area that was not injured, and this skin will be accepted permanently by the patient's tissue. And in order to obtain enough healthy skin to cover a large area, that usually is very, very hard, we are using methods of expanding the tissue that was harvested. In terms of complications, there are a few that are known to be associated with burn patients. We have what is called a curling ulcer, also called a stress ulcer, which is a gastric or duodenal ulcer that occurs in patients that have serious skin burn. And in order to prevent that, we are providing medication continuously that will reduce the gastric production of chlorhydric acid. For the patients that went through grafting procedures, the most serious complication will be the contractures that the skin will go through, especially in the process of healing. And that happens if a burn will extend over a movable body part and will create those kind of fibrous scarring that will in the process of healing. In order to prevent that, what we can do is to splint, exercise, and provide pressure therapy in order to prevent contractures. In terms of long care therapy, there are rehab phases of care that the patient will need to go through, that most of them are long and very difficult. Most of them will be in order to return to normal daily type of living that they had before. The treatment will aim to release contractions, and other treatments will aim to revise scar tissue to prevent disfigurement and to improve the specific part of the body function. Sexually transmitted infections, they have, or STDs, they are also called sometimes sexually transmitted diseases. Their incidence is especially higher in adolescents, and the diseases are covering a wide range of conditions, most of them highly treatable, and the most important part is to prevent them more than even treating them. For the infants, when we are looking in this category of age, infants can be infected prenatally or during the birth process, especially if it's a vaginal birth. Any child infected after the neonatal period must be considered the victim of a sexual abuse until proved different. Any case of severe or repeated pelvic inflammatory diseases or severe genital warts are warning signs that that child needs to be tested for HIV. We'll look into a few of those. And when we are talking human papillomavirus, or HPV, is the most common STD seen in adolescents. There are a few viruses that are all included in the big group called HPV. And many times the HPV infection will be asymptomatic, will go away on its own. However, the virus may stay present in the body and cause genital warts, and later in life can cause cancers, especially cervical cancers in females. That's why it is by now the standard to immunize at age 11 or 12 to prevent infection with HPV. We do this immunization in two sets, one vaccination and one booster. And we do that before they start their sexual life. Gonorrhea, one of the most commonly reported communicable disease in the United States. It's also called popularly like clap, the drips, the dose, and as general symptoms, they will have mild primary symptoms, especially in females. Most of the time will go undetected, and as a result of that, it stays untreated. And will stay untreated until it becomes more severe and will cause a serious pelvic disorder. It's one of the main causes for sterility in both males and females. There are several drugs that we can use to treat gonorrhea, the drug of choice being ceftriaxone or rocephin, followed by a week of oral azithromycin or doxycycline. And this is to prevent and accompanying usually chlamydial infections. We will need to interview the adolescents and ask to name their sexual contacts because those need to be treated also. There will be some penicillin-resistant strains of the gonorrhea. So because of that, the penicillin is no longer an effective drug of choice. We need to educate our patients and explain that the body will not develop immunity to gonorrhea. They can reinfect themselves and they may expose others when they are engaging in sexual activities or other high-risk sexual behaviors. Chlamydia. In a way, chlamydia is replacing nowadays gonorrhea as the most common and fastest spreading bacterial STD in US. The symptoms can be mild, and because of that, the diagnosis might be delayed. And as a result of lacking treatment, there are some serious complications, and also the spread of the condition and transmission to others may occur. Chlamydia may cause what is called PID, pelvic inflammatory disorders, that cause sterility in females because it produces scarring at the level of the fallopian tubes that in the future will prohibit the passage of a fertilized ovum towards the uterus. A lot of times a tubal pregnancy, an ectopic pregnancy that is tubal, is a consequence of a previous chlamydial infection and the stricture at the level of the fallopian tubes. In males, sterility is the result of an inflammation of the epididymis, epididymitis, that could have been easily treated with doxycycline or azithromycin, which are the drugs of choice for chlamydia. If we have a pregnant adolescent, erythromycin and or amoxicillin can be used in order to avoid the teratogenic effects of the other two drugs. Again, in this case, the sexual partners must be treating as well, as I said before. Genital herpes also can be considered an epidemic condition in the United States. The disease starts with a vesicle that ruptures and forms a painful ulcer for the STDs that we are considering now is for the genital area. However, there are two types. There's type 1, the oral or the labial one, and we have type 2, the genital one. This initial ulcer may last for up to 12 days, and the patient will have recurrent episodes that will last way shorter, 4 to 5 days. There is no cure. Once the patient will have contacted, the genital herpes will stay forever in their body with recurrent episodes. There is a treatment that we can offer to our patients with acyclovir or Zovirax that is useful in relieving and suppressing the symptoms as well as making the attacks less common. There is a higher risk for cervical cancer in patients that have genital herpes. That's why females that have genital herpes need to have an annual pap smear. Genital herpes will not be transmitted to the fetus in utero. However, if the mother has an active case of an active lesion at the time of the delivery, there is a full indication for cesarean section in order to reduce the risk of infection of the fetus by passing through the vagina and infecting in the process. Syphilis, it's also an increasing problem in the United States. It's caused by a spirochete, Treponema pallidum, and the syphilis can involve finally every part of the body if untreated and have devastating long-term effects. In the case of this condition, an infected mother has a high risk of transmitting the infection to their unborn infants. Mainly, the syphilis is spread is primarily by sexual contact. The primary stage will appear about 3 weeks after exposure, and without the treatment, we'll get into a secondary stage or a latent stage, and only later will be a tertiary stage. Now, if we are looking into the latent stage, the cardinal signs of primary stage will be a chancre, which is a hard red, painless lesion at the point of entry, where the spirochete entered the body. That lesion can appear on the penis, on the vulva or the cervix. It can appear on the mouth, lips, rectal area, anywhere, any other area that was involved in a sexual contact. This lesion will disappear, and what is important about this lesion is mainly the fact that is not painful, and a lot of times the patients will ignore it because it's so unpainful. Once ignored and not treated, the condition will get into the second stage, where the patient will show up with a rash, sore throat, and fever that can appear 2 to 6 months after the original infection. Signs of both the first and second stage will disappear without any type of treatment. However, the spirochete will stay in the body, and this latent period can persist for as long as 20 years without symptoms. However, the blood test will be positive, and that's how we can recognize the patients and treat them at any point if they will reach for medical help and will be tested. The tertiary stage of the syphilis has severe neurologic and cardiovascular damage with mental illness and other system involved. The treatment is very simple. Syphilis responds to 1 IM injection of penicillin G. If the patient is sensitive to penicillin, we can provide them with oral doxycycline, tetracycline, or erythromycin that can be administered as alternative treatments. The treatment needs to be done before the tertiary stage in order to prevent the neurologic and cardiovascular complication to develop, and that can lead to death. Another sexually transmitted infection is the one with a human immunodeficiency virus, HIV, that this virus will develop lately into the final form of the infection with HIV, which is called acquired immunodeficiency syndrome, or AIDS. HIV is attacking and destroying the T helper lymphocytes, those that are marked as CD4. The T helper are those lymphocytes that are involved directly in the immune response to viral, bacterial, and fungal infections, and also are involved in preventing malignant cells from developing in the body. So the development of the AIDS varies among patients. We have a category A. They are called mild symptomatic. They are HIV positive and they may have one or two symptoms like enlarged spleen or liver or lymph nodes, and they may have frequent respiratory or ear infections. We have a type B or a moderately symptomatic patient where they are HIV positive and they have illnesses as bacterial pneumonia, herpes simplex virus, herpes zoster, or persistent fever, more critical illnesses associated. And we have what is called a category C patient, that they are severely symptomatic, they are HIV positive, and in association with that, they will have bacterial infections up to encephalopathy, lymphomas, TB, severe failure to thrive, or any type of other opportunistic infections. Transmission occurs through contact with infected blood or blood products, during transfusion, sharing of infected needles, exposure to infected body secretion through sexual contact, as well as from an HIV positive woman to her unborn fetus or newborn. There are various ways of transmitting the condition. We need to educate our patients, especially the teenagers, that they are not immune to it. They have the tendency, teenagers have the tendency to have an attitude of impunity. That means that they believe that nothing can hurt them. And because of that, they have an increased rate of high-risk sexual activities in this group range, involving multiple partners, not using any kind of contraceptive, or sexually transmitting preventing methods. Infectious mononucleosis is common in the adolescent population, and it has a popular name of kissing disease. So mono is caused by Epstein-Barr virus, and Epstein-Barr virus is one of the herpes virus groups. The organism is transmitted through saliva. There is no immunization available, and the treatment is purely symptomatic. All the adolescents and young adults are susceptible to the disorder. However, it's seen sometimes in younger children. In terms of manifestation, there is a wide range of symptoms, from mild to severe, and sometimes has symptoms that may mimic hepatitis. Among the symptoms, they will present with fever, sore throat, with enlarged tonsils. They can have thick white membrane covering the tonsils, may have petechia, those red spots on the soft palate, swollen lymph nodes, and an enlargement of spleen that usually will be seen in association with extreme fatigue and lack of energy. The diagnosis is based on the clinical symptoms and lab evidence of lymphocytes in the peripheral blood with 10% or more abnormal lymphocytes on the peripheral blood smear. Also, we can do the diagnosis on a positive heterophil agglutination test. We have another test that is called the monospot, which is very valuable. It's rapid and sensitive and pretty much inexpensive, that detects significant agglutinins at lower levels and may allow for an early diagnosis. In some cases, infectious mono can be confused clinically with a strep infection because of the fever and the appearance on the throat and tonsils. There is no actual cure for mono, and the treatment is based on the symptoms. We'll need to provide analgesics and antipyretics to whenever there is fever or headache. We need to provide fluids and soft blend diet, especially when the throat is very irritated. Corticosteroids are sometimes recommended to relieve the severe throat and the fever. When the patient comes with fatigue, we can recommend the bed rest. For those with an enlarged spleen, we need to caution both the child and the caregiver to avoid any type of contact sports that can increase the risk for an injury to the spleen. Also, because it's associated with a weak immune system um, due to the disease, the child and the caregiver must take precautions to avoid any type of secondary infections. In most cases, the mono is usually has a course that goes uncomplicated with the fever and sore throat that may last from 1 week to 10 days. Fatigue would usually disappear in up to 4 weeks after the first symptoms. However, in some cases, may be as long as 1 year. Question 9. Tell whether the following statement is true or false. A young woman who is HIV/AIDS positive delivers a child and wants to breastfeed. As with all new mothers, breastfeeding should be encouraged. It's false, and the rationale is that infants usually are infected through the placenta during prenatal life. However, if they were not infected through the placenta or in the birth process, they can become contaminated through breastfeeding after. So we would like to prevent that. Communicable diseases of the childhood include those conditions that require specific precautions to prevent spreading the infection. And nowadays, we'll follow the CDC guidelines regarding transmission precautions. Those are the diseases that not longer than about half a century ago, it was hard to survive as a child, like measles and mumps and whooping cough and poliomyelitis even. Um, in the modern world right now, we are using immunization, and that has changed the outcomes drastically. And because of that, a lot of the caregivers nowadays, we are not aware that the fact that we don't have those um, conditions anymore is due to the immunization, and the anti-vaxxers need to be educated into the importance of the vaccination and acquiring immunity in a different way than through the active, through having the condition. So prevention is the most important part in when we are dealing with communicable diseases, both for the adults and for childhood. But when right now we are talking more about pediatric communicable diseases. Um, so in order to understand and have a way to um, have a common language, I would like to define a few elements. And we define it as active immunity, that immunity that is acquired after receiving a vaccination through a immunization with a vaccine. We call natural immunity that is genetically determined, and it gives a person a resistance to a pathogen, or that is acquired through encountering a disease. And we have the passive immunity. It's that immunity that a person that encounter a disease is provided by receiving antibodies from an immune person. So in terms of preventing communicable diseases, we will need to teach the caregivers in terms of modes of transmission of communicable diseases. Either they are droplet, direct and indirect contact with body fluids and discharges, contaminated blood, food, or water, and educate in how to prevent communicable disease to spread.